Welcome to the session of the ultrasound of the hip. I am Dr. Amit Sahu, consultant radiologist in Max Hospital, Saket, New Delhi. We will be discussing the technique of ultrasound of the hip, how to perform it, and what are the clinical uses. Talking an overview of the ultrasound of the hip, we'll be talking about basic ultrasound scanning technique, transducer positioning and essential sonographic bony landmarks, which will be reviewed, and scanning in two orthogonal plane will be emphasized. Limitations of the ultrasound in the evaluation of the hip will be also talked on. The ultrasound, while doing the ultrasound of the hip, the various segments needs to be evaluated: anterior hip, lateral hip, posterior hip, and the medial hip. Anterior hip, we need to see the anterior joint, iliopsoas, tendon and the muscle, tensor fasciculata, sartorius, neurovascular bundle, rectus femoris, and the iliopsoas bursa. Lateral hip, we need to see the adductors, which is the glutei and the tensor fasciculata, and the trochanteric bursa. Posterior hip, we will need to see the hamstrings, sciatic nerve, ischiogluteal bursa, and in the medial hip, the adductors. Coming to the anterior segment, the patient should lie in supine with hip and knee extended, foot neutral, slight external rotation. The transducer is positioned superinferiorly over the anterior hip or the groin, lateral to the femoral vasculature along the long axis of the femoral head and neck. This is how the probe should be placed, where you are able to see in the ultrasound image the femoral head and neck. This is the joint capsule. This is the iliopsoas tendon. This is the short axis view of the anterior uh, aspect of the hip examination, where you are able to see the femoral head cartilage. This is the iliacus muscle, this is the psoas muscle, this is the iliopsoas tendon, this is the femoral artery, and this is the tendon of the iliopsoas again. In case of anterior longitudinal oblique view, we need to see the tensor fasciculata. This is the anterior superior spine, and this is the posterior fat which is seen. The pitfalls in the anterior assessment of the knee is if the hip is internal rotated, it can be associated with the convex outline of the anterior joint capsule, and the anterior joint recess may artifactually measure more than 7 mm in thickness. This should be normally less than 7 mm, and this is often wrongly diagnosed as a joint effusion where none actually exists. If the transducer is not placed correctly along the long axis of the femoral neck, or if the transducer gain is not set correctly, the synovium may appear significantly hypoequial and may simulate joint effusion. Similarly, if there is always some intra-articular tissue anterior to the femoral neck, which can be normal, it is important to resist overdiagnosis of synovitis or effusion. This is the positional pitfall where we are assessing the anterior hip and there is some internal rotation of the hip joint. In case when we are assessing the lateral segment, so the patient's hip and knees should be gently flexed in lateral decubitus position. The transducer is placed transversely over the lateral aspect of the proximal femoral shaft and scanned upward till the triangular shaped greater velocity protuberance is encountered, as I will show you right now. So this is the position where the hip and knee is slightly flexed. The patient is in lateral decubitus position. This is the probe should be kept in the short axis view, where you can able to see the protuberance of the vertical velocity. This is the anterior aspect, and this is the lateral aspect of the velocity, where the anterior aspect gluteus minimus and the lateral aspect medius is attached, over which lies the iliotibial band. In lateral longitudinal view, the probe should be kept longitudinally, where you are able to see the gluteus medius. This is the greater trochanter, this is the attachment, this is the femoral head, and the gluteus maximus goes over this and attaches posteriorly. In lateral view, the gluteus minimus needs to be seen deep, where it is attached to the anterior aspect in the short view, and iliotibial band is seen over it. I would like to explain the anatomical attachments of various structures in the greater tuberosity. So this is the greater tuberosity where you are able to see the anterior facet. This is the lateral facet. In anteriorly, as I told you, there is gluteus minimus gets attached. There can be a small bursal space here. Medius attaches to the lateral facet, lateral aspect, where again there can be a bursal space. The tensor fasciculata muscle and the tendon goes attached with the gluteus maximus, and between the maximus and the bone, there can be a bursal space. The posterior segment assessment is done in the patient in the prone with the hip and knee extended. transducer is placed in transversely between the greater tuberosity, distal tuberosity loop for hamstring tendon and sciatic nerve, and then following the structures distally in the posterior thigh. So this is the position where the patient is lying prone and the hip and the knee is extended and the probe should be kept here. This is the ultrasound image where you see the gluteus maximus more superficially. This is the sciatic nerve. What it is and the greater tuberosity is seen here. In the long axis view, you are able to see the quadrants femoris attachment and this the sartorius, the distal tuberosity, and the we can see the attachment of the hamstring, semimembranous and the semitendinosus. In the medial segment, patient thigh is abducted and externally rotated, knee is bent, transducer over the bulk of the adductor, and three muscle layers are recognized on the axial, the short and long axis oblique planes. So this is where the in the medial aspect the probe should be kept, and in the short axis you are able to see the adductor longus, brevis, and magnus from superficial to deep. Similarly, in the long axis view, where we can able to see the long axis longus, brevis, and minimus along this plane from superficial to deep. So, before concluding, I would like to just emphasize that the diagnostic ability of musculoskeletal ultrasound is based on an operative training and experience, the patient's habitus and aptly chosen clinical indications, a good grasp of the anatomy, sound ultrasound machine technique, and knowledge of the limitations of the ultrasound modality are essential for a safe ultrasound practice. It is best that a rheumatologist adopts a career plan for learning in case of musculoskeletal ultrasound relevant to rheumatology, because many times we do have patients from the rheumatology clinics for the assessment of the hip joint. Thank you.